Here is Dr. Prasanna Venkatesh, and he'll be talking to us about the novel 3D effective holographic ophthalmic AI metaverse with augmented reality. Dr. Prasanna, please.
Yeah. Thank you, Rohit Shetty sir, for giving me this opportunity on this innovation session. So for the next few minutes, I'll talk four components of the innovations that we have done. One is the teaching pedagogical one, the another one is the clinical diagnostics, surgical simulations, and then the AI. So things which was once thought to be a science fiction, all of us would have seen this movie or movies resembling holograms, which was once thought to be science fiction is now no more science fiction, it's a science-based reality. So we started slow and steady with the LiDAR technology that is available in the smartphones, and this is the QR code for Android and the iOS that have innovated respectively. So the models were actually created with a template, a three-dimensional template, and in the smartphone, it was given for the user. So you can see that the right-hand side, the video is actually synced with the left-hand side. So the pedagogue or the teacher who's actually teaching the students onto orientation. So we wanted to first start with accelerated learning or pedagogy. So on day one, can we show how the lens or the fundus or the anterior segment structures really look? So you can see that the videos are so the videos are actually synced with each other. The right hand side is actually synced with the left hand side, and you can see the phone actually navigates. Yeah, the phone actually navigates as a three-dimensional spatial tool, and you can go ahead and see the fundus as well as the real fundus images were given, and also you can see the angle structures were used, a photoreal visual reconstruction for the angle as well. And this is again another video of the phone where we did a screen recording. You can see even a beautiful angle structure which mimics as real as possible for an YAC counseling or for teaching the structures as an SLT or an ALT for that matter. And we navigated towards to the fundus as well. You can see this is a normal fundus. Now we have an NTG patient where there is a splinter hemorrhage, and also the color fundus or the autofluorescence can also be collected. And then you can see we have moved towards an RNFL defect. So even you can use this for retinal pathology. So the idea was teaching pedagogy. So we started with making an atlas of fundus, atlas of angle structures. Can we have something to have a pedagogical augmented reality teaching tool in the smartphone? So that was how we started, and we validated it and published it in the European Journal of Ophthalmology 2023, that is last year. And then also there was a commentary on the same in the IJO 2022. Then we wanted to push ourselves further in can we have a subtractive module for a virtual dissection. So ophthalmology and neuro-ophthalmology structures, we tend to not really get to do dissection of structures that we wanted to. So we started giving buttons here, and the user can actually choose buttons. There were no app available that can actually subtract structures and then go in and see the structures. So we sat with our anatomy and we read the anatomy, reconstructed it whole in 3D, and then you can see the user can choose and use subtractive learning, and that with augmented reality was possible for neuro-ophthalmology brain as well as for the eyeball models was used. And then pushing us ourselves further, can we use some simulative modules for smartphone? So in this on the left hand side you can see, so the models have been loaded, and now I'm moving my smartphone towards the pupil. So this is like a direct ophthalmoscopy. So you can talk however you want on direct ophthalmoscopy, but none like actually showing them this is how you do it. So you go in, you come back. So when you do it multiple times for field workers or for your neophytes or your postgraduates who are starting their curriculum, this really makes a lot of difference. And also for e-counseling on the right hand side, you can see, we have seen that showing their patients their own images in a smartphone, I think it makes a whole lot of difference. And we are trying to move into EMR as well with their own case sheets coded to them at the end of the day. So then we pushed into the headsets, that is the ophthalmic diagnostics. So the same models that we had created for smartphone learning, with this headset, the HoloLens that we got, so you can see that the models were actually embedded into the meshwork, and the touch with a haptic sensation, a pseudo 4D or a three-dimensional orientation, where the same examination of the patient, eye being a three-dimensional organ, can be examined 3D itself. So you can see the same splinter hemorrhage patient case sheet. So now we can examine it in 3D. The angle structures can be extrapolated and examined, and then you can see the RNFL defect here, which is being examined in color as well as in autofluorescence and infrared. So we published it in the August issue 2022 in the Indian Journal of Ophthalmology, and now we are pushing ourselves further to incorporating OCT also into it. So when a patient walks into the hospital, you get it into the software under 60 seconds with no instantaneous chat time. You get the holograms of the OCT extrapolated into it, and I think eye as a three-dimensional organ has to be examined in the 3D with the imaging that we have, multimodal imaging, and before and after treatment you can counsel the patients with it. And this is again another collection of flecked retina and retinitis pigmentosa, and also for low vision rehabilitation counseling. Mostly if you see, I think we are seeing it in neuro. This is making a lot of inbounds because cognitively tend to imagine it, and with subtractive element added into the holograms, it's being a game changer. Moving on to the third part of migrating into the surgical simulations. So this was an idea when I got when I was doing one of my MIGS cases. The stent was superficially implanted. This was a 2022 case of mine where I had to place the second stent first. Then I had to take and reassess the implant that was actually hanging because it was an under-implanted one. I was almost losing it in the phaco wound because that time there were not many teaching modules in 2021 when MIGS were hitting India. So all's well ends well, I was able to recover the stent and then place it well, and the patient is a happy patient. But then I went back to the drawing board, and can we do something for surgical simulations beyond cataract, because cataract, phaco, SACS are something which is well taken care of. So that is when we went back with this particular HoloLens, the three-dimensional one, where we went back to the drawing board and we had the anatomy of the angle already there. You can see that the left hand side and the right hand side are synced with each other. On the left hand side you can see actually what the user is seeing through his eyes. So we made the MIGS more easy because this is three-dimensional spatial orientation. So every time when you implant the stent correctly or when you do a bang or a KDB, it gives you a visual cue that you are doing it right. So you practice more and then enter into the real field so that you get it right. So we patented this innovation of ours, which is available for HoloLens users as well as for Geo users, and also published the same in IJO. So coming on to the last part was the artificial intelligence, which goes hand in hand with these kind of inventions, where the software application which we innovated, we did a different concept of human intelligence with AI. So we wanted to utilizing human intelligence in AI because AI is ultimately like human. It has a CNS just like the neural network of the humans. It has to undergo a growth phase. So we train the machines by having two human interfaces, having a human annotation to train it, having a human validation to correct it if it's moving in the wrong direction. So each image was sat by a human ophthalmologist, a glaucomatologist, and a retina person, and you can see the amount of depth. Some images were taken 15-20 minutes to train. So at the end you break the black box. Sometimes in AI we don't know why it is predicting the way it is predicting. So we wanted to have the diagnosis along with the findings. You can see even an RNFL defect can be predicted, and explainable AI is something that we are moving forward to, and we are pushing ourselves further and further. So now we are working on anterior segment protractors as well for diagnosing where is the trabecular meshwork, the green dot that you can see, then identifying the scleral spur, where is the scleral spur, then getting your protractor there. And though there are many angle protractors now with the mix that is coming in, when you open up the angle which I'll be showing next, so we need to invent and reinvent ourselves because there is more to understand in this region after you make the procedure. So we are pushing ourselves with UBM, Anterion, ASOCT and Scheimpflug imaging. It's a multimodal project that we are doing, and you can see with every training the results are much better from 24, 27, 24 is now 22, and now it's as one difference as much as possible. So this is something that is very promising. We are moving to OCT as well. Me being a glaucoma person, I am pushing myself more into glaucoma per se. So how we can diagnose, not only diagnose, but also grade the glaucoma with severe, moderate, as well as differentiate the glaucoma with the anterior segment modules. And this is the study that I was talking about, which is due for publication in IJO. There are 5 to 6 different mixed surgeries. Each angle anatomy is different, and we are working on these segments so that we get the outflow channels the way it is, how the Schlem's canal is opening up in different procedures, be it the excision procedures like a KDB, bang or a suture gate, or stenting procedures like an eye stent or eye stent inject. So every model has to have its own growth, and there is no end to this learning, my dear friends. I am using human in the loop machine learning, where human goes hand in hand. You can use it for diabetic retinopathy, and you can use it for what not, OCT, and there is no ending to it.
You have to sum it up.
Yeah. So that's all there is to, my dear friends. We are going to have an hands-on between the machine and the thing for a better humanity. And I would like to thank once again, and this is my team behind it. Thank you once again, sir, for giving me this opportunity to cover on all the 4 different facets. Thank you.
Start with Ashish. No, comment on this, all the retina people, then Sheet.
I just had one question.
Yes.
So, does it show the actual patient's pathology, or
Ma'am,
let's
this
say
is,
they're having macular edema and the actual picture of the patient, or you just
No.
have models of
this
different
is not
pathology
an,
and you just show
this
them?
is not an imaging tool, ma'am. It is a
Okay.
translational tool.
Okay.
So this is not an imaging tool. Yeah.
So I have a question, Dr. Prasanna. How repeatable is it? Like when you try to counsel the retina, is there an eye tracking system? Like first time you see something and you counsel this is there. So when you repeat it, it has to be accurate so that when the minor details.
So with the spectralis that has come into the field, sir, there is a Brooks membrane opening for fovea BMO axis. So
Yes.
with that, what I am getting is we are able to get exactly the macula where we want to and the optic disc where we want to. And incorporating the lens star along with it, even the eyeball biometry and this fovea BMO axis, we are able to reconstruct the models as precise as possible. So I am using those technology also into creating these
That
models.
is what you are planning to.
Yeah, we are already doing it, sir, but we are refining it as we speak. Yeah.
So
Thank you.
one thing you could, because you already have a
Yes, sir.
3D visualize, one thing you should really consider doing is incorporating macular perimetry
Okay, sir.
into that thing, because see, if you are adding your OCT images there, you have a fundus images,
Okay, sir.
and if you're able to look at the macular thing. And one thing which is which I feel is very necessary in today's, it was there as a one tool. It used to be, it's particularly Maya. Maya was stand for macular integrated something. See, it was giving you a preferred retinal loci, multiple things was giving. That machine does not exist.
Okay.
Using the same stimulus, you can look at how you can build those macular responses. Something you can incorporate
sir.
in it, which probably will become then a teaching module and also a diagnostic module.
Definitely will work on it, sir.
Ashish?
Yeah.
Prasanna, great talk. So,
Yes, sir.
means I just want to know that where do you see after 5 years means being
Sir,
used?
we have the applications ready. It is just that the products have to be, there has to be many institutes forthcoming with this 4D holographic simulators, be it Oculus, Geo. If Geo is going to come up with something cheap, our apps are ready to be launched. It is just that we have it in the cloud, we have it in the mesh. So I think we are taking one day at a time. So if the HoloLenses or the Geo lenses are ready, our apps are ready. So it's just that the smartphone is not ready, but the apps are ready, sir.